Thank you very much for the very detailed introduction. My name is Zhimin. I'm a PGY2 at Neurology at the Westchester Medical Center. Today, my topic is about surviving residency. ING because I'm a PGY2 and I'm surviving. So when we talk about the residence, I think everybody are very familiar with like a typical day on the floors as a resident. Like every morning we come very early, like we change shift, we do sign out, and then we do the pre-round or going to the lectures. Then we go into the morning round, social work round, we attend the lectures, and then afternoon rounds, or you are on call or going to the night shift. So every day we are doing the floors, but what do we need to be a residency for the correct characteristics? So everybody was thinking about we need to be a quick learner, of course, very hardworking. We need to work very fast to quick response and attention to details, teamwork, communication, passion, and also have very good physical mental health. When we write this into our personal statement, what does this mean? And what can be a very good, like the standard to evaluate a resident? This brings my very favorite picture, the ACGME core competencies, which is very focusing on all the like requirement to be a good resident. Means we have to focusing on patient care, medical knowledge, practice-based learning, system-based practice, professionalism, and also very important communication skills. First of all, patient care is the most important thing for a resident. I can tell you some of the stories during my residency. I'm a neurology, so I'm gonna focus on some neurology cases. At night, our hospital is like one resident working at night, especially taking care of all the ED and like floor consults, including all the stroke code. And attending, they work at home and they cannot do the physical exam for the patient. They cannot like taking history for the patient. We are the main person to doing this and then present to our attending. For example, one of the stories, a patient came here as like a stroke code. One of the night resident just came there and asked the history and told the patient, the attending at night over the phone. A patient with history of stroke came here with the right upper extremity weakness. But I think the most important thing is patient has respiratory failure. So the patient should go to the medicine team and then done. Then, of course, the ED will not let the patient go home. So medicine team came here and talked to the resident. Are you sure this patient does not have any acute stroke? The resident told the ED team and the medicine team, I'm 100% sure. This patient had a history of stroke. So the medicine team admitted the patient. The key problem is the patient blood pressure is around 220s. So they are taking care of the respiratory failure, also taking care of the hypertension urgency. So they should decrease the blood pressure. But the next day, the MICU team just said, let me do the MRI because the patient is too altered to being just a hypertension urgency. And they think the respiratory failure is because of the altered mental status. So they did the MRI brain, which showed the patient had acute right side stroke. So because of this stroke, the patient blood pressure should be permissive to hypertension, but they already decreased the blood pressure. And also the medicine team, of course, the attending had a long conversation, tried to figure out what's going on with the resident who did on-call. And they were thinking the resident on-call did not do a very good job at night. He should start like this already, like making the patient care is not very safety because they didn't diagnose acute stroke and they decreased the blood pressure. The second thing is like another story is like when I was working at night, and one of the patient came here, had history with the right peroneal nerve decompression. It's like the patient had history of foot drop, and they just did the procedure. Patient come here with worsening right lobe extremity weakness, also back pain. The neurosurgery team was initially just saw the patient, oh, please lift up your legs, and the patient was not able to lift up legs. So they were thinking, oh, this probably with the back pain and maybe some cord compression. So they were spending 7 to 8 hours to working on the MRI to figure out what's going on with the patient back. Then the MRI, of course, was not unremarkable, and they finally called me at night. So I went there, did the very detailed physical exam, and then every single muscle, and we do very, very detailed exam because the attending is at home. They are not able to do the exam. So I figured out the problem is because of the procedure. The patient right peroneal nerve or worse, like it got worsening, recompressed after the procedure. Maybe because of the scar issue or whatever. So then the next day, when I present this case to the attendees was thinking, okay, so asking me 3 times, are you sure the patient like were the problem was because of the right peroneal nerve and was not because of the right side? Because I did a very, very detailed exam, so I had confidence to tell the attending. So this will totally change the management for the patient. So the patient care is the most important thing. The second is the medical knowledge. As a residents, we need to gain our medical knowledge like day by day. We can check in the up-to-date, we can talk into the seniors, and also read the consult notes. Also read the attendance note. As a resident, we also have the right exam. You take the exam every year and to try to gain more medical knowledge. Also, we can do the, like as neurology, we have the ANA question of the day, and we do all the questions to build up the medical knowledge every day. This is very important is because with very enough good medical knowledge, and it's very practical during all the consultant course. For example, a patient come here as a stroke code, came from BHC, from the behavior, like has history of psych, like disorders, and was came here stroke code as unresponsive. And we are around the code, and I quickly saw the patient. The very tricky exam is when you ask the patient to lift their arms, and then the patient was not drop the arms and the hands onto the face. Instead, they drop it like slowly, to avoid to hit the face. So when I saw this, I know, okay, this is functional. So you have more confidence to gain enough time to deal with this acute stroke case. So the medical knowledge is very, very important for our daily practice and also the experience. The next is like system-based practice. As a resident, we not only to learn all the medical knowledge, we also have to learn like how does the system work? How does the hospital works to be functional? Because the hospital has so many different departments, including the social worker, the rehab, and also the billing department, all the nurses, all the MRI teams, different teams. And the residents, we have to do the social round, like a meeting every day, and to talk about the patient care and the discharges. How do we make the as a part of the residency, as part of the hospital, to making the patient care more smoothly? Like during the social round, for example, this case, a patient came here to getting the plasmapheresis, which is like a kind of like a procedure to taking care of all different autoimmune diseases. And the patient usually going to get 5 different sections, like every other day. And the last session is Friday, and the patient is gonna be discharged to the rehab, evaluated by the physical therapist. How can we make it more like functional is we tell the social workers ahead of time, oh, the last session of the plasmapheresis is Friday, and we talk with the plasmapheresis department, tell them, can you do this in the early morning on Friday? So after this, the social worker can take care of the transportation and send the patient to the rehab. So they don't have to stay here for the long weekend, just waiting for the transportation to the rehab. So because you tell the social worker, and the social worker and the plasmapheresis team, they can make everything more efficiently. So the patient do not have to stay here for the long weekend. They can be discharged after the on the Friday morning. Next is like practice-based learning and improvement. Is I think during the lunchtime, they also talked about the evidence-based practice, because for this is the medical field, like the medical knowledge is one part, and the other thing is we need to make sure everything we've done is evidence-based. And for example, a patient came here like with dementia, very rapid, like aggressive dementia, also have like vivid dreams and also constipation. We were thinking about, okay, so this kind of thing as look like a Lewy body dementia, because patient also have like a hallucination. So we were thinking about this, but actually we have to be evidence-based, based on the guideline, doing more like exam and doing more like test. Finally, after all of this, the patient actually was diagnosed with CGD, which is mad cow disease. So if we already discharged the patient with just Lewy body dementia, this is actually not the correct diagnosis. So we need to go through all the guidelines to make sure what we did are the evidence-based. Professionalism. I learned one thing from the ED team was, because one night we have so many different like transfers. Some of the transfers actually are very simple transfers. And I almost lost my patience because I did so many calls and so many consults at night when I was the only resident also taking care of ICU patients. So I went to the ED. I initially was not happy for so many consults. And one of the ED attending looked so calm. I asked him, when you are like at ED taking care of so many urgent things, and how can you make you look so calm? And he told me one thing. He said, on the first day of his residency, his attending told him one thing is, never lose your cool. Oh, sounds very cool, because at ED, at those kind of stressful working environment, if you can want to keep your cool and you can keep you more calm, and you can avoid to being too aggressive or like have very bad manners to the patient and family. So I learned from him. When I also did multiple stroke code, multiple consults, I always think about this. We are trying to come here to help the patient and families who are like very sick right now, just being cool. And there was one like a sample is from one of my co-residents, and he did multiple consults when he was doing the on-call by himself. He was carrying the stroke pager. And after he did one ED like stroke code, and there was another stroke code called at the neuro ICU. And the neuro ICU, it's usually like running by the neuro resident. And the resident came there and saw the patient and the attending in the like a room and telling them, I'm already very busy taking care of the ED consult and calls. Why you as neuro ICU team, it's okay to manage the patient by yourself, call stroke code. He told this in front of the patient, family, and also the attending in ICU. So we can imagine if we are the patient and family in the room, heard about the resident came into the room and telling to the attending who is assessing the patient, think the patient really needs that imaging because of the possible stroke. They, of course, will lose the like trust for the whole hospital team. So the attending was very calm and told the resident, please run the code, stat, and we can talk privately, like later. So they ran the code, and the next day, the resident just came to our every week we have the ops meeting talking about different services. He brought up this topic again, said, I don't think it is right to run the stroke code in the neurocritical care unit because you should take care of the patient by yourself. And he brought this topic in the public again without talking to the attending privately. So this is totally not professional because this is not a good sample for build the trust between the patient and the doctor. Also, it's not good for the teamwork, especially in front of especially you argue with the attending in front of the patient and the families. So never doing this kind of conflict thing in front of the patient and family. So the last thing is last critical is interpersonal communication skills. During the morning session and in the afternoon, everybody was talking about communication skills because communication skill is very, very, very important as a human beings and also as a doctor, especially as a resident. You have to be the bridge at the attending and patient and families. Every day we have to give the family updates for what's going on with the patient, what's our treatment plan, and what's the discharge plan. The other is through this we can build trust with the patient and family. Also, it's very important to communicate with the social workers for the discharge plan, talking with the physical therapist, the PT, OT, also the pharmacy. There's another sample where it's when we downgrade the patient from the ICU team to the floors, and we have to give very detailed sign out also as a communication. One of the patient was at neuro ICU for almost 2 weeks, and they were not very satisfied with the care. So they already requested the transfer to the other healthcare system. Unfortunately, the other healthcare system denied the transfer. But the ICU team did not sign out this to the floor team. So the floor team was not aware of the situation. When the patient arrived to the floor and the floor attending went to talk with the patient, examine the patient. So went into a very, very unpleasant environment because the patient need very frequent suction, but the nurse did not do it very well, and the patient family were suctioning for the patient, so the patient decided. When the attendant went there, and the family was not satisfied, of course, but they did not know that the attendant did not know the family is very demanding. So this made the patient care even worse because of the miscommunication and mis-sign out. So the communication not only between the patient, between the doctors, the residents, and the families, also between the different teamworks, different teams. So this is also very, very important for the residency skills. And all those kind of skills are evaluated by the different teams, the staff, the co-residents and fellows, and the mentors, program director, and also our supervisor. Almost every rotation and also every monthly and semi-annual and also annual evaluation. Except those 6 core, we have extra points as to survive the residency. Some of us have to do some research for especially some QR project is mandatory for most of the residency program. The journal club and doing the presentation in the M&M. Also learning the resources, and we seek the feedback to self-reflection, give feedback, and seek a mentor. Also, we have to give education to the medical students, to giving them feedbacks, being a teacher to teach them, joining some conferences, and these are all very important for the fellowship application. The other thing is to keep us very healthy, as not only physically but mentally, is always find something fun to enjoy your personal life. Thank you.
Thank you, Dr. Xu. Very helpful tips on how to survive residency. And we may have more questions during the panel discussion. So we are going to move to our final talk by Dr. Jin. And Dr. Wesley Jin graduated from Wenzhou Medical University in 2017. He finished internal medicine residency training in Cook County Hospital, Chicago, Illinois, and currently is working as a full-time hospitalist in a teaching hospital in rural Maryland. His clinical interests are point of care ultrasound use, and he is joining Westchester Medical Center in New York as an academic hospitalist this coming April, and which means next month, right? All right, okay, welcome. And by the way, we also have invisible audience on Zoom. So if you have any questions, you can type your question in the chat box, and we will ask the speakers at the end. All right, welcome.
Greetings, everyone. I've been sitting there for an entire day. I realize my topic probably don't apply to most of you guys. So this is my third year practicing as attending, and last year was actually my second job hunt.